Okay, let's unpack this. We've got this massive strategic document in front of us, and it's all about implementing an integrated perioperative information system, or IPIS.
Right. And you can tell just by the sheer size of this plan that it's a huge institutional priority.
It really is, and you've asked us to do a deep dive here to really get into a document that sits at this uh, really high-stakes intersection of clinical care, health economics, and some pretty serious informatics.
It's the ultimate triple threat, isn't it, for any hospital administration. So our mission today, I think, is to pull out the core drivers for this big technological retooling.
And understand the proposed solution, right? The nuts and bolts of the IPS itself.
Exactly. And critically, we need to detail the tangible value proposition. We have to see how this system is supposed to deliver both, clinical safety improvements and the financial gains that the institution needs.
And this isn't just about updating IT systems, is it? It feels like it's about acknowledging a fundamental change in how surgical and anesthetic care is even delivered.
That's the perfect way to put it. Before we can even look at the IPS itself, we have to understand why this demand for integrated data has become so critical.
And that starts with the evolving role of anesthesiology.
That's the real starting point. Anesthesiology used to be, well, strictly synonymous with the operating room. You manage the patient for a few very intense hours inside that one single contained environment.
That model is completely gone.
It's been shattered, just shattered by specialization and expansion.
We're seeing this massive expansion into what they call non-OR settings now. It's not just the main surgical suite anymore.
Not at all. Anesthesia care is now routine in these really complex areas like interventional radiology, endoscopy suites, the cardiac catheterization labs.
Basically, if a procedure is complex or high risk, an anesthesia team is going to be there.
They're there. And that breadth of procedures is supported by this just explosion of subspecialties.
We're talking dedicated experts in pediatrics, cardiothoracic, neuroanesthesia,
Pain management, both chronic and acute, critical care medicine, palliative care, even sleep medicine. I mean, this diversity of skills has really created a whole new operational model.
and that operational model is this push toward what's being called perioperative medicine.
Yes.
So instead of just being procedural specialists for a few hours, anesthesiologists are now in this unique position to manage the patient's entire journey.
The whole continuum.
Yeah.
From the moment of scheduling through pre-op optimization, the intraoperative care itself, the PACU, critical care.
All the way to post-discharge management.
It's an expansive, really exciting role, but it demands a level of communication and coordination that, well, paper charts and fragmented software just cannot support.
Right. You can't manage a 90-day episode of care if the data gets lost between 3 different clinics and 2 different floors of the hospital.
It's impossible. And that need for technological cohesion is being, I'd say, ruthlessly enforced by these massive external pressures.
Which brings us to the mandate for change. Let's talk about the economic pressure cooker that's really driving this whole strategic plan.
Well, the reality is that healthcare costs, particularly in the U.S., are just escalating. And simply treating the patient in isolation is no longer sustainable from a business perspective.
Even though the advanced surgical and diagnostic tools are, themselves, inherently expensive.
They are. But what the payers, the insurance companies, Medicare, what they're scrutinizing now isn't the cost of the surgery itself. It's the downstream economic damage.
Hold on, you mean the costs that come from failure?
Exactly. They are starting to deny payment, or at least refusing to absorb costs that are associated with avoidable complications, extended post-discharge care, and the big one, unplanned readmissions.
So if a patient has an avoidable complication, the hospital, the provider system, now has to bear that financial risk.
They eat the cost. And that immediately leads us to this fundamental economic mandate, this necessary market-driven shift to value-based payments, or VBP.
We're moving away from the old fee-for-service model.
Which often incentivize volume, right? The more you did, the more you got paid.
And now we're moving to VBP, which fundamentally aligns the quality of the outcome, the overall costs, and the defined goals of care.
It's a tectonic shift. And it translates into concrete mechanisms like alternative payment models, or APMs. The main way they put the financial risk onto the provider is through what are called bundled or fixed payment methodologies.
Okay, so let me see if I have this right. Under a bundled payment, the hospital and the doctors get one single fixed lump sum to cover an entire episode of care. So for a hip replacement, that would be from the pre-op assessment all the way through 90 days after discharge.
That is precisely right. And if that patient has a complication that doubles their length of stay in the hospital, the provider absorbs that cost. There's no extra payment.
So that mandates efficiency. It mandates rigorous adherence to best practices and error reduction, because failure is no longer just a clinical problem.
It's a massive financial risk.
That really clarifies why the hospital leadership is so deeply invested in this. They benefit financially if they can improve efficiency and cut complications, because they get to keep the savings from that bundled payment.
Sure.
But how is this enforced on the individual doctor?
That's where legislation comes in. The Medicare Access and CHIP Reauthorization Act of 2015, they call it MCRA, created something called the Quality Payment Program, or QPP.
Okay.
And that includes the Merit-Based Incentive Payment System, MIPS. MIPS is what compensates physicians for improving outcomes while simultaneously reducing costs.
So MIPS is the mechanism. It's what ties that macroeconomic pressure of VBP directly to the individual physician's performance and, well, ultimately, their income.
Yes. And conversely, poor performance leads to financial penalties. So whether we're talking about huge structures like accountable care organizations, ACOs, or just a simple bundled payment, the financial implications of efficiency are just enormous.
And you can't succeed in these new models unless you can rigorously measure quality and cost across that entire perioperative journey.
Which is impossible without an integrated system.
So the data mandate is crystal clear. But the tech isn't just for economic survival, right? It's also necessary to support these really revolutionary new models of collaborative care that are already proving to be successful.
We're talking about things like the Perioperative Surgical Home, or PSH, and Enhanced Recovery After Surgery, ERAS protocols.
ERS protocols are becoming almost standard now. They focus on these evidence-based pathways to optimize a patient's recovery.
And the results are just. They speak for themselves. We see reduced complications, much shorter hospital lengths of stay, and a significant measurable reduction in opioid use.
Which is a huge win on its own.
A massive win. And the PSH concept takes that coordination even further. The American Society of Anesthesiologists proposed PSH to align the goals of the patient, the provider, the hospital, and the payer by creating one unified system.
So it requires this coordinated management from scheduling all the way through post-discharge, getting surgeons, anesthesiologists, and floor nurses all on the same page.
And, crucially, implementing those evidence-based protocols throughout that entire continuum. The source material here is very clear that the fragmentation we currently have, pre-op assessments in one clinic, intra-op care by one team, post-op by another, it fundamentally compromises both safety and efficiency.
And the IPIS is the technological foundation you need to overcome that fragmentation.
It's what transforms these multidisciplinary collaborative ideas like PSH and ERS from some abstract ideal into a functional, hardwired clinical reality.
Okay, so that brings us to the vision and the specific strategic goals for this IPIS project. If the mandate is to solve fragmentation and meet these VBP demands, what are the 4 pillars this system is specifically designed to achieve?
The institutional requirement is, well, it's unambiguous. An integrated system is necessary. And the mission statement for the IPS is really defined by these 4 primary objectives.
Pillar 1, enhance patient safety and clinical quality.
Absolutely paramount. This is all about hardwiring safety into the clinical workflows, replacing manual, error-prone steps with automated processes, especially during those high-intensity, high-stress periods.
Pillar 2, the financial engine. Improve operational and financial performance.
Right. This is about efficiency. We need better ore utilization, we need to reduce supply waste, and we need to maximize legitimate reimbursement capture by ensuring complete, legible, and accurate documentation every single time.
Okay. Pillar 3 addresses that communication and coordination challenge we were talking about. Enable coordinated multidisciplinary care models.
This is the communication layer. It ensures that the critical care team or the pain management service has immediate, shared, and highly accurate information from the OR team.
Which reduces the risk of just devastating errors during those information handoffs.
It does. And the final pillar, which I think unlocks the future of care, is to establish a foundation for data-driven improvement.
Big data.
This is leveraging big data. The amount of structured data generated during anesthesia is just perfect for research, quality measurement, and feedback. The system has to collect it in an organized, searchable way to allow for continuous quality audits.
So let's move into the proposed solution itself, the Integrated Perioperative Information System. The centerpiece of this entire strategic investment, the thing that actually generates all that high-fidelity, high-volume data, is the Anesthesia Information Management System, or AIMS.
The AIMS is the engine. And it's fascinating how long people have recognized the need for this. The sources here mention an integrated monitor and recorder system that McKesson used way back in 1934.
Wow, 1934. So the idea of automating documentation and a physiologic data capture is almost a century old.
It is. It's really the complexity of modern care and the whole regulatory environment that finally forced its adoption.
And you mentioned that market penetration in U.S. academic centers just jumped from 10% to about 75% by 2014, driven partly by incentives from the American Reinvestment and Recovery Act.
That's right.
So what defines a mature AIMS today? It has to meet three essential requirements.
First is comprehensive encounter recording. The system has to seamlessly document all the phases, the preoperative assessment, the intraoperative management, and the PCU phase, all using a single, continuous patient record.
Which means you need network accessibility everywhere that patient might go.
You do. Second, the core capability, automated physiologic data capture. This is that high-volume structured data stream.
This is where it really shines.
This is where an AIMS earns its keep. The intraoperative phase generates a massive amount of data. I mean, we're talking about more than 50 different parameters describing a single minute of care, all sampled from the patient monitors and the anesthesia machine.
So things like arterial blood pressure, end tidal CO2, heart rate.
Volatile anesthetic concentrations, tidal volume, ventilator mode, you name it. The AIMS samples and logs these values automatically, which frees the provider from all that repetitive manual entry.
And the third requirement is provider-entered clinical documentation, the human element.
Yes, this is where the anesthesia provider adds the necessary context medications given, procedure annotations, any unanticipated clinical events, their assessments. It's the synergy between the automated data and that human annotation that creates the truly comprehensive record.
And these requirements deliver a huge quality benefit. I thought this was fascinating. The sources note that studies comparing handwritten charts to AIMS records found a smoothing effect in the handwritten ones.
It's a really interesting insight into human nature under pressure, isn't it?
It is. Essentially, providers tended to record less extreme values, so lower maximum systolic pressures, higher minimum diastolic pressures, than what the automated records actually showed was happening.
Right. The AIMS provides an independent, unbiased, and complete record. And crucially, it solves the issue of illegibility and documentation errors that tend to cluster during high-intensity periods like induction.
When the provider's attention should be 100% on the patient, not on the chart.
Exactly. But this high-fidelity data is useless if it's just stuck in a silo. We have to talk about the architecture, how the AIMS integrates this data into the entire hospital ecosystem.
Here's where it gets really interesting.
It does. We can probably bypass the super technical definitions of servers and networks, but we have to understand the necessity of the core architecture. If the central server hosts the AIMS application, you need mechanisms for the clients, the workstations in the R, to access that data securely.
And this all relies on the core principle of keeping patient data locked down within the local hospital network, the intranet.
And protecting it from the external worldwide network, the internet.
And the critical boundary, the security gatekeeper between those two, is the firewall.
The firewall is key. It ensures that only legitimate, predefined traffic can enter the internal network. Security is just paramount.
And because the modern clinician needs to access charts and data from outside the hospital, say, checking on pre-op labs from home, they rely on a virtual private network, a VPN.
The VPN creates an encrypted, secure tunnel for the data. It basically makes the external computer functionally act as if it were safely connected inside the hospital network.
The information flow itself is complex. We see these visualizations in the source material like Figure 4.2 that show data from the OR, the PACU, the ICU, the lab, radiology.
It all flows into these specialized gateway devices and software, and then it integrates into the Central Enterprise Electronic Health Record, the EHR.
And the end result has to be EHR accessibility across the entire institution.
That's the goal. The provider rounding in the ICU has to have full, immediate access to the intraoperative record that was just generated down in the OR. That continuity of care is the foundation of the perioperative surgical home.
For that seamless flow to work, we need interoperability standards. Otherwise, trying to get different systems from different vendors, monitors, lab systems, EMRs to talk to each other would just be a nightmare.
A nightmare of proprietary coding. Historically, the standard for exchanging data within an institution has been Health Level 7, or HL7.
That's the older, widely used standard. Great for transmitting standardized results like lab values and basic monitor data.
Right. But HL7 wasn't really designed for today's world, was it? It wasn't built for mobile access or for massive external data exchange.
No, which is why the modern standard, Fast Health Interoperability Resources, or FHIR, is so essential.
FHIR is much more like how modern internet applications exchange data. It uses simple, standardized requests to a central resource. It's essentially the universal translator for health data.
And it's designed for easier integration, and crucially, it has modern security features that are necessary for accessing health data on your phone or tablet.
Exactly. Standards are important, but the regulatory hammer enforcing all of this complexity in the U.S. is IPA, the Health Insurance Portability and Accountability Act of 1996.
This defines our need for robust security.
IPA established the entire regulatory framework, and it particularly defined what is considered protected health information, or PHI. It drives every requirement for encryption, access control, every security measure we put in place.
And the definition of PHI goes so far beyond the obvious things like names and diagnoses. We really have to recognize how granular this data protection requirement is.
The surprising thing is just how far PHI protection extends into the digital realm. We all know medical record numbers and names are protected, but the list of IPA identifiers also includes all geographic subdivisions smaller than a state like your city or zip code.
And even details like web URLs, your IP address, biometric identifiers.
And even vehicle and device serial numbers.
That's a key point. So
Yeah.
even something that seems as benign as the serial number on an infusion pump or a ventilator, if you can link it to a specific date and a specific person, it becomes a legal liability under the security rule.
Absolutely. And the four major HIPAA rules enforce compliance. You have the privacy rule, which covers how PHI can be used, the security rule, which focuses specifically on electronic PHI or ePHI.
Right.
Then there's the enforcement rule, which dictates sanctions like monetary fines, and the breach notification rule, which forces organizations to report security breaches. Compliance is a continuous day one requirement.
Okay, let's pivot back to the bedside. How is all this rigorously protected, integrated data actually used to help the clinician in real time? This is the concept of decision support.
Right, the IPAS as a high-tech co-pilot.
I like that.
Decision support leverages all that collected data to actively help providers optimize care and stick to evidence-based protocols. And it really comes in two flavors, starting with the more subtle one, passive decision support.
This uses design choices to guide behavior, leveraging what's called the anchoring effect, things like pre-checked boxes or default doses.
The best example is structured documentation templates. If you look at figure 4.4 in the materials, those predefined charting elements, like the sequential tasks for position, induction meds, administer antibiotics, they function as an aid memoir.
A memory aid.
Exactly. They facilitate standardized documentation and guide the workflow, which helps ensure critical tasks like giving prophylactic antibiotics on time aren't missed or delayed.
Then we move to the much more sophisticated systems. Active decision support. These are the systems that are continuously monitoring the record and providing real-time feedback or alerts.
Yes, systems like the AlertWatch or multi-parameter system you see in figure 4.5. This isn't just a basic monitor, it's an integrated display. It combines real-time data with calculated parameters like total fluid balance or additive MC values, and it displays active alerts.
The image shows alerts for really critical issues like low MEPI alert 55, high cumulative vasopressor bolus dose, and tachycardia. These are basically rule-based systems looking for a breach of best practice.
And figure 4.6 gives a very specific, tangible example of an embedded active alert for tidal volume. A pop-up box literally notifies the provider that the patient's mean tidal volume is outside the recommended range based on that patient's ideal body weight.
So it gives the problem, the patient's specific target range, and a prompt for action, all instantly.
It's incredibly powerful. It instantly ties evidence-based medicine to the specific patient at the point of care.
But designing these systems sounds incredibly complicated. There must be a huge alert design challenge.
There is. If the alerts fire too frequently, clinicians start to ignore them, which is the dreaded alert fatigue.
Right.
So the design architecture has to include three elements: the rules definition, so what constitutes a violation, the surveillance process, so repeatedly checking the patient's status against the rules, and the notification method, a clear, non-intrusive alert.
And the calibration is crucial. I mean, if the EHR only updates monitor information every 60 seconds, it can't realistically alert you to a rapid second-by-second drop in oxygen saturation.
That's a great point. Those fast-moving events still need to be handled by the direct bedside monitors. The AIMS focuses on larger trends and rule adherence.
It's about clinical management rules, not immediate physiological crisis detection.
Correct. And it has to be targeted. An alert for an in-room provider might focus on drug interactions, while an alert for a supervising provider might focus on managing their required concurrency ratio across multiple ORs.
Okay, now that we've established the strategic need and the technical solution, let's get to the payoff, the value proposition. How does the IPIS translate all this complex technology into measurable clinical and financial benefits?
We can start with the clinical benefit, enhancing clinical quality and patient safety. The IPI's capabilities translate directly into reducing human error and variation. It's about hardwiring safety.
Let's look at that framework connecting the capability to the impact. First up, the automated, unbiased data recording capability.
The impact on care there is foundational. It reduces the risk of documentation errors during those high-intensity periods, like induction and emergence. It ensures a complete and accurate legal and clinical record.
Next, clinical decision support, CDS.
The impact there is that it guides adherence to evidence-based protocols. It ensures prophylactic antibiotics are given on time, ventilator settings are appropriate for the patient's size, glucose control protocols are maintained. CDS is really the path to standardized, high-quality care.
What about the IPI's ability to provide seamless information handoffs?
This is critical for patient survival after the procedure. It improves communication of crucial information details on a difficult airway or the specific timing of long-acting opioids to the PCU and ICU staff. Mitigating that fragmented care dramatically reduces the risk of postoperative complications.
And finally, the support for evidence-based protocols like ERAS and PSH.
Its impact is that it facilitates the real-time implementation and later the auditing of these multidisciplinary programs, which have been proven to reduce patient lengths of stay and complication rates significantly.
Moving beyond the individual patient, that rich AIMS data can be collected for profound secondary use for quality improvement and for large-scale research.
This is that data-driven pillar in action. The data gets converted into objective measures of quality, which allows for crucial performance feedback.
And Figure 4.7 is a great example of this, an automated performance feedback email. This is essentially a personalized report card for a doctor, right?
It is, yes. It provides an individualized compliance score for key metrics that are derived directly from the EHR data. Things like whether train of 4 monitoring was used, was reversal medication given, success rates for low MAP prevention.
And the key element seems to be the benchmarking. You are compared against all other attendings.
That peer comparison mechanism is a remarkably powerful lever for sustaining compliance with quality measures across the whole institution.
And that capability scales up massively into research. The EHR data is the fuel for these huge-scale initiatives, like the Multi-Center Perioperative Outcomes Group, or MPOG.
That scale is the difference between an anecdote and real evidence. Catastrophic complications are, thankfully, rare. You need thousands, sometimes millions of patient records to quantify the true risk factors for events like difficult mask ventilation or an epidural hematoma.
And the IPIS makes that volume of research possible.
It enables studies that characterize patient outcomes using information drawn from the entire hospital record, not just the 2 hours they spent in the OR.
Okay, shifting to the financial side. How does the IPIS deliver on its promise of driving operational efficiency and financial performance?
It starts with the most immediate return on investment, improved billing and charge capture.
Right. Compared to manually reviewing paper records, the AIMS automatically extracts case elements, start times, stop times, procedure codes, who was in the room, which drastically speeds up the billing process.
And it ensures accuracy. It increases reimbursement capture by making sure specialized procedures, like an arterial line placement or continuous cardiac monitoring, are correctly documented and billed.
So it captures things that might otherwise be forgotten in the heat of the moment.
Exactly. Automated alerts have been shown to drastically increase the capture of billable procedures. Next is enhanced concurrency management. This is critical for legal and payer compliance regarding those supervision ratios.
Okay.
In models where one supervising physician is overseeing multiple concurrent rooms, the AIMS checks in real time that the provider isn't exceeding the maximum supervision ratio defined by policy.
So it prevents claim rejection before the claim even leaves the hospital.
Instead of weeks later when it's denied for a documentation error. This assurance is vital for survival under those volume-based payer models.
The data also feeds OR utilization analytics. This tackles the elephant in the room. The operating room suite is the hospital's most expensive resource.
It absolutely is. The OR has enormous fixed costs. AIMS integration allows for sophisticated analysis of the process flow. We can analyze procedure time variability using historical data stratified by surgeon to predict future time needs much more accurately.
And more importantly, you can rigorously track turnover time between cases.
That's the big one. And reducing that turnaround time by even a few minutes spread across 15 operating rooms.
Can translate directly into adding the capacity of an extra operating room day every week without any new capital investment.
The efficiency gains are tangible and they are measurable. And finally, all of these measured efficiency and quality metrics become the foundation for value-based contracts.
Because to successfully negotiate and manage those bundled payment agreements, the hospital needs data.
It needs to prove it can control costs and deliver high quality at the same time. By rigorously tracking cost components, efficiency gains, and quality compliance via the IPIS, the institution gains the necessary visibility and leverage to thrive under these VBP models.
So we have the vision, the technology, and the value proposition.
Yeah.
Now we have to talk brass tacks, high-level implementation and risk management. You can't just flip a switch on a system this complex.
No, it requires a structured, programmatic approach. You have to acknowledge the massive scale of the architecture changes and the behavioral changes required from the clinical staff.
And the structure here implies a logical phased implementation approach.
Right. Phase 1 is all foundational. This is your needs assessment, your vendor selection, establishing the core technical architecture, defining the initial rules for decision support and quality metrics.
Then phase 2 is the core AIMS deployment.
Rolling it out to the major OR suites, rigorous testing of the automated data capture interfaces, and making sure that initial EHR integration is rock solid.
And phase 3 is full enterprise integration.
Yes. Deployment to all the non-OR sites, optimizing advanced features, fine-tuning those decision support algorithms, and scaling up the quality reporting modules.
The sources emphasize 2 continuous work streams throughout all these phases: data security and compliance and staff training and change management.
Data security has to be continuous. The plan must mitigate both internal and external threats while strictly adhering to IPALACA. So that means physical security for servers and logical security complex passwords, two-factor authentication, encryption for all data.
And the VPN, as we noted, is vital for maintaining that logical security for legitimate remote access.
It is. And the change management piece is where so many technology rollouts fail. You absolutely have to overcome provider frustration and resistance to change.
The system has to be usable.
It has to be. The documentation templates have to be customized to fit site-specific practices. And the sources note this difficult trade-off. If you customize mandatory documentation fields, you improve data quality. But if you make too many fields mandatory, providers will just click through to complete the case, which undermines the data's integrity.
So it's a careful balance between enforcement and usability.
A very careful balance. To manage all this complexity, a robust governance structure is absolutely necessary to ensure accountability.
Right, so you need coordinating bodies.
3 of them are essential. The Executive Steering Committee provides the high-level strategic oversight, making sure that the project aligns with institutional financial goals and manages the resources.
Then the Clinical Informatics Work Group focuses on the user experience and the medical content.
They are the liaison between IT and the frontline clinicians. They define the clinical content, they set the rules for decision support, like those tidal volume parameters, and they ensure the workflow integration is clinically sound and useful, not burdensome.
And the technical project team.
They manage the infrastructure, the server architecture, deployment schedules, network maintenance, and the integration interfaces with all those monitors and specialized external systems.
Finally, we have to address risk. What are the key failures the institution has planned for, and what are the mitigation strategies?
The first and most immediate risk is system downtime, whether that's planned for maintenance or an unplanned failure.
And mitigation for that.
Reliable backup processes, which in this case means reverting to paper-based charting for that limited period and having a defined, standardized process, a downtime workflow, to re-enter that data into the AIMS once the system is back online.
The second risk is data integrity and incomplete documentation, which goes back to that provider frustration.
The strategy there involves using customized mandatory documentation fields to enforce minimal compliance while minimizing the burden. And you use feedback like those performance feedback emails to encourage sustained compliance across all providers.
And the final risk is perhaps the newest threat introduced by this very technology: provider distraction and misuse of electronic devices in the OR.
This is a significant concern because vigilance is paramount in anesthesia care. Studies confirm that electronic devices, including the Ames workstation itself, can introduce new sources of distraction, often self-initiated, involving personal matters or even educational activities unrelated to the immediate patient.
So how do you mitigate that kind of distraction?
It requires a layered approach. You develop local policies that clearly differentiate between clinical, educational, and personal usage of electronic devices, and you enforce a high degree of vigilance. But there's also a potent deterrent that's embedded in the technology itself.
You mean the logging capability?
Yes, the use of perioperative information technology is meticulously logged. This means that any activity performed on an electronic device contemporaneous to the patient care being provided can be reviewed later.
Which creates a significant medical legal consideration that strongly encourages appropriate non-distracting use.
So what does this all mean for the strategic future of the institution?
The IPIS is really dual-purposed. It's simultaneously a clinical safety tool that generates unbiased data and active decision support to improve patient outcomes.
And it's a critical financial and operational necessity, enabling compliance with VBT models and driving those efficiency metrics.
The IPIS isn't a replacement for clinicians.
Not at all. It's the necessary technological infrastructure required for anesthesiology to successfully expand its role into comprehensive perioperative medicine supporting PSH, ERAS, and all these collaborative models of care. The data generated by this system is already transforming the field.
We've focused heavily on the technical complexity and the immediate gains, but the real future value lies in how this IPIS data foundation evolves. We're already seeing these massive multi-institutional research databases like MPOG aggregate all this high-fidelity information.
And that infrastructure is leading us toward the next frontier. The ability to conduct seamless, pragmatic clinical trials that are embedded directly into the EHR workflow. You can test a new fluid management strategy or a different pain control protocol, not in a small, isolated study, but on thousands of patients across dozens of institutions.
And the data is just collected as a byproduct of the standard clinical record.
It is.
Which raises our final provocative thought for you to consider. How will the ability to test new clinical hypotheses and strategies instantaneously on thousands of patients fundamentally change how we define evidence-based medicine in the operating room? When your data collection system becomes the research engine, the timeline between a clinical observation and a verified best practice just collapses, and that changes everything about how we define quality care.